You'd think I'd be good at it. Okay. All right, good morning. Well, we're going to talk this morning, as we do before every surgery morning, and we take a long time doing it. We actually have a very special VIP visitor, and that's the daughter of our associate plastic surgeon in Costa Rica. And so...
The sister.
Sister, oh, I'm sorry. I thought you look so young.
He's 7 years younger than me.
I see. Okay, good. So we're very happy to have you visiting. Her plane did not get in. There was a delay. So she missed yesterday's Tuesday clinic. I know they're saying, boy, we wish we could have. Yeah, they were saying, well, we wish we could have missed that clinic. Stuck there all that time. But so your surgery is not till Thursday, but you get to listen in this morning, and we'll talk a little bit about any questions you and your family have. So.
Okay.
You and I talked a little bit about the types of surgery. We talked about the costs of surgery and how you kind of decide what kind of risks and benefits you want to take. In other words, I don't know if I can put words in your mouth, you maybe can correct me, but if you had to pay a little bit more and get a more effective surgery, is that a good choice? Are we taking a cut rate surgery because we're doing a cut rate price? Or how does the pricing of the surgery choices affect the different kinds? And kind of my opinion about which surgery is more effective and weight loss, and those are kind of the topics that I touch on them a little bit in the right way. And I think when you and I talked on the phone last night, we were talking about the fact that you wanted to ask those questions in kind of a nice way and not a kind of a, you didn't want to sound like it was an unpleasant question. It was a reasonable question. And I think those are reasonable questions. So one of the things we've been talking about is we have different flavors of patients. Some people who are very heavy, and some people who are medium heavy, and some people are not so heavy. And so each person potentially might have a surgery tailored for them. So for example, in my mind, the lap band kind of works kind of okay. And it's a kind of a good choice. Good morning! Come in the house.
Good morning.
No, come in. We were just talking. Good morning. So the lap band is kind of okay. I mean, we have a lady who it didn't seem to help her at all. But if you look on average, some people get some weight loss from the lap band, but they don't seem to get the massive weight loss. And so the gastric bypass, I think, is kind of a more powerful surgery, but the Roux-en-Y gastric bypass, I think, has its own downsides. Now, when you and I have been talking, we've talked about a couple of choices that we are willing to offer. I wouldn't be willing to do a Roux-en-Y. I just don't, in my opinion, not that they're a bad choice, and there are a lot of good doctors who choose it, it's just not my favorite choice. And I guess I might be willing to do it under certain circumstances, but I'm not crazy about it. We talked a little bit about a new kind of surgery that's called the sleeve gastrectomy. And to understand what we do for that, we kind of think of how the stomach looks and cut out the outside edge, leaving just the inside edge, a long, narrow stomach, which should remind you of the mini-gastric bypass, because we don't cut it out and throw it away, but we do run the staple gun and we make a inside edge, long, narrow stomach. So there's some similarities there. The sleeve gastrectomy, although it's gained a lot of excitement because it seems to be slightly more effective than the lap band without having plastic in, and it also cuts through the stomach and the vagus nerve, so you would think there would have decreased ghrelin. It's not as effective as the gastric bypass. And it's not reversible because you can't go down to the pathology lab and get the outside of your stomach back and put it back in. So in contrast, say that our patient from this morning who has a lap band, when she had problems with it, she took it out, and I think we heard her say yesterday that to remove the lap band took only like 15 or 20 minutes. Well, that's a good positive to have a way to get out, or an exit strategy. And obviously, the sleeve gastrectomy has no exit strategy, so you're stuck with it. But it works pretty well, and you and I had talked, we might be willing to do it if you wanted to. The disadvantage of it is that it has a pretty high failure rate over time. We think that obesity is a pretty tough adversary. Lots of people have gone onto the battlefield or into the ring against obesity and went to fight obesity and lost. So like diet and exercise and Atkins diet and, my opinion, kind of lap band and previous old kind of surgeries like the old stomach stapling. They've kind of gone into the ring, so I'm going to take you on, Mr. Obesity. And I think what it shows is obesity is a pretty tough foe. It's a pretty tough nut to crack. It's a pretty challenging adversary. So my way of thinking about it is that the sleeve gastrectomy is not up to the task. Not that it's a bad surgery, and it works in somewhat, but it has a pretty high incidence of failure. It stretches out, the stomach stretches out over time, and people gain their weight back. They also don't lose that much. They lose about half as much as a bypass patient. And so it's not a bad choice. It has some good features in that it doesn't have the bypass malabsorption, but the bypass malabsorption is what is giving the increased effectiveness to the bypass types of surgery. We are kind of biased, and so I need to admit that this isn't an objective assessment, it's a biased assessment, but the mini-gastric bypass is quite a powerful treatment for obesity, so that if you go in against obesity, the mini-gastric bypass routinely wins that battle. The band, not so much. The sleeve gastrectomy, not so much. And the mini-gastric bypass has a lot of the advantages of those lesser procedures. It's reversible. So God forbid you got a terrible complication from the mini-gastric bypass. You got a malabsorption of something, iron, okay? Or you got an ulcer. You can undo it. Let's suppose they come up with a pill that cures obesity. That'd be great. And they said that you can take this pill, if you can imagine, and it will make you thin and healthy and wealthy and smart and friendly. Okay? But you can't have it if you have a mini-gastric bypass. Well, we'd undo all of our mini-gastric bypasses and I'd go into the pizza business, But the nice thing is the mini-gastric bypass is very easy to undo. Let's suppose you got a terrible disease, an awful cancer all throughout your body, or you become infected with the AIDS virus, okay? And your body was wasting away and your doctor said, you need to undo your weight loss surgery. You need to be able to eat again because you've got this terrible AIDS or Ebola virus or something awful, okay? Well, fine. We can undo your mini-gastric bypass in 30 minutes. That's an advantage of the band, not so much of the sleeve gastrectomy. Now there's another one that we talked about yesterday, which is a junior version of the mini-gastric bypass, and that is the small mini-gastric bypass stomach, which is a lot like the sleeve gastrectomy, with no bypass. In other words, if the mini-gastric bypass has two parts, a small narrow stomach and a bypass of the intestine, we could just skip part 2.
And how do you, but you don't take out, so how do you, can you describe what do you do?
Mm-hmm. Do you know how we would make the stomach for the mini-gastric bypass? Mm-hmm. So you start the staple gun, staple, staple. Now imagine that there are two pieces of stomach laying next to each other, the long, narrow inside and the regular part. Mm-hmm. Now at the very bottom, just connect them back together again with a narrow connection.
Right. What would the effect on Greenland be for that?
Decreases it. So yesterday in clinic you actually saw somebody who had a mini gastroplasty. That was Miss Schroeder, who had the revision, because she had the mesh in and we had the so we had a difficult time at her first surgery. We couldn't get to the intestine, couldn't do a bypass. And so we've probably done about 150 or 200 of the mini gastroplasties, just the stomach version. And their results are a lot like the sleeve gastrectomy in the band, which is not great. Good morning.
Good morning.
Come on in. Oh no, you're doing fine. So the mini gastroplasty, the sleeve and the band, just attack the stomach, and they're kind of okay. They are not as powerful. They're not as effective as the bypass. So they're not bad choices. They've got some benefits. The nice thing about the mini gastroplasty is it's very easily reversible in contrast to the sleeve, and they both get about the same weight loss. So our numbers, depending on how much you weigh to start off with, is the sleeve gastrectomy, the band, and the mini-gastroplasty all get about 50 to 70 pound weight loss. So Ms. Schroeder only got 12 or 16, so sometimes less, but the average is around 50 pounds, something like that. Whereas the average weight loss for the mini-gastric bypass in a 300-pound person is 140 pounds. So the mini-gastric bypass, very powerful. The mini-gastroplasty would be my version of kind of a stomach-only therapy. I think it has advantages over the sleeve and advantages over the band, but as we talked about the other day, they're all okay. None of them are bad. They all have their own limitations and risks. And then we talked about the cost, and all the cost of all those is the same. I mean, not the band. I don't know what the cost of the band is, but...
Well, you don't do the band. No.
Right.
Yeah.
So the choices are a mini-gastroplasty, a sleeve gastrectomy, or a mini-gastric bypass with a short bypass. The price for those would all be the same, because they all take about the same time.
And so, just to be clear, on the mini-gastroplasty, you will have a decreased hunger effect.
Yes,
Okay.
but it's mild.
Okay. So it's not the same as.
It's people say, like, you know, I think you heard Ms. Schroeder. She said her daughter had a mini-gastric bypass. They both noticed that their desire to eat was decreased,
Okay.
and their hunger was decreased.
Right.
Her daughter lost 140 pounds. She lost 16.
Right. But with the decreased volume in your stomach, you're still going to feel full when you, I mean, because the volume's the volume.
Right, right. You have that feeling of fullness.
Yeah. And easily reversible as well.
That's the neat thing. In fact, Ms. Schroeder, again, is a great example. Not only was she easily reversible, easily revisable. In other words, let's say you wanted to be conservative. I want to be cautious and careful. I'm going to do the smaller operation, just the gastroplasty, and then come back. And if you don't get enough from that, we can add the bypass. And that's what we did in her, not for exactly those reasons, because we couldn't get through all the mesh at the first surgery. But in her case, it was easy to add to her bypass, I'm sorry, to her surgery, because she had a gastroplasty, and that made it very easy for us.
Excellent. All right.
Is that kind of, or that talking about what we,
Excellent.
okay.
Yeah, that's perfect.
All right, good.